We go. There we go. We will plan to send this recording to all registered participants after the meeting, along with links to other documents shared during presentations or in the chat additionally. Second, we will have 3 different presentations today, and there will be limited time for questions after each presentation. Feel free to put your questions in the chat during the presentation. And if you'd like to, once the presentation is over, feel free to use the raise hand feature, and we'll go around for questions there. We'll work to get to as many questions as possible before moving on to the next presentation. And so with that, I want to turn it over to Jen Griffiths, who is our Vice President for Policy and Advocacy at ACT, who will introduce our first presenter.
Good morning, everyone. Thank you so much for taking time out of your Monday to join us for this important conversation about school-based Medicaid in Alaska. I want to start by just acknowledging the energy and effort of so many individuals and groups across the state, some of whom are in this virtual room with us today, related to this topic. As Teresa and I started asking questions and doing research on this issue, we were so excited to discover how much amazing foundational work already existed, and how many conversations about school-based Medicaid were happening in different corners of the state. So our goal today is just to provide a space to share those foundational pieces of information with a larger group of stakeholders. Some of this information won't be new to you, other pieces might be. So our hope is just by coming together that we can kind of create a shared understanding about the opportunities for school-based Medicaid in Alaska, and then use that shared understanding to develop a shared strategy for some next steps. So that leads me to our first presenter. Lena O'Rourke is with the Healthy Schools Campaign, a nationwide nonprofit that provides support and advocacy on issues that are at that intersection of health and education, including school-based Medicaid. So Lena, thank you so much for joining us today and just helping ground us in kind of a national perspective.
Jen, thank you so much. And thank you all so much for being here. And good morning to all of you. I am based in Washington, D.C. So it's actually like the end of the school day. Hope my children figure out where the snacks are on their own sort of time frame here. So it's a true pleasure to be with you all instead. I'm here representing the Healthy Students Promising Futures Collaborative, an effort of the Healthy Schools Campaign. And my job, as Jen said, is to really just level set and make sure we are all starting from the same foundational information in place. And because I sit at this national federal lens space, to give a sense of what's happening in other states, because I think that really puts into some context what the world of the possible is. So that's what I'm going to do. I'm going to talk. I can talk forever on this topic. I'm not going to do that today. I'll try to keep my remarks pretty tight so we can have time for question and discussion, because I think the presentations that follow me get much more into the Alaska specific landscape. And I think that's where you really need to spend your time. So I was the world's worst presenter and changed my slides at the last second. So Teresa and Jen were nice enough to humor me, so I'm going to run them myself. So give me 1 second while I figure them out. Is that showing the whole screen? Jen, I can see you on my thing. Yep. Okay. Just as a point of reference, I think everyone knows this with the Zoom, but I think it's worth me just saying, I'm a terrible multitasker. And now that I have my slides up, I cannot see the chat. So if anyone is trying to get a hold of me or to break in and ask a question, please just do it. Just ask the question. And then we'll switch to the chat afterwards, because I won't be able to toggle between the things while trying to manage all of this on my own. So I apologize about that up front. But I also know my Zoom limitations. So as I said, I am doing School Medicaid 101 and giving this national perspective. First, I just want to kind of credential where I'm coming from so that you have a sense of really what I'm looking at. I'm working with the Healthy Schools Campaign, and I've worked with the organization for a very long time. It's a national organization, but we are based in Chicago, the organization is. And we've spent the last 6 or 7 years, really with a laser focus on supporting student health through increasing access to additional funding for school health services through Medicaid. And we run the Healthy Students Promising Futures Learning Collaborative, which is a collaborative of state teams that work with state Medicaid, state education agencies, and school districts specifically on school Medicaid and how to improve it. So we do a peer learning environment to help states understand best practices, to talk to each other, and to really home in on, again, that world of the possible. So that's where I've learned a lot about what I'm doing and where I'll share some of the stories from other states. But very specifically, our work focuses on improving that connection between health and education outcomes and building coordination between the three legs of the stool: the school districts, inclusive of the providers, the Medicaid agency as the payer, and then the state education agency as the glue that ties it all together. And we are thinking about how to expand school Medicaid outside of the IEP, and specifically to cover all students so that Medicaid can act like Medicaid and reimburse a provider for delivering a service to any Medicaid enrolled kid, which is a little different than how school Medicaid works now. So school Medicaid has been around for like 30 years, in one way or the other. And Medicaid has paid for health services, both physical and behavioral health services, that are included in a student's IEP. It does not, or did not historically, cover services outside of the IEP. So students in general education, or those even with a 504 accommodation plan, those services are not automatically covered in a school district, but those services in the IEP, the health services in the IEP are. And while it is a tiny fraction of overall Medicaid spending, it's like 1% of all Medicaid spending, it's a lot of money that comes into schools on a nationwide basis. And it really is a significant source of funding specifically for student health services. It's sustainable, and while it's not always adequately paid, it is a guaranteed source of funding for those services in those IEPs. And let me be clearer about what I'm talking about on this school Medicaid piece. And I'm going to pause here for a few seconds because this is really important. There are lots of ways that Medicaid pays for services in schools. Medicaid is paying for services for children and adolescents, for physical health services, and for behavioral health services in a school setting in lots of different ways, in lots of different school districts across the country. And all of them are valid. All of them are super important. And all of these different methods really help students access the care and services they need. And I am talking about one tiny piece of this. All of my remarks are really going to be focused on the district employed providers or district contracted providers, where the school district is the biller, and the school district and or the providers use their provider, their Medicaid number, to bill. That is different and distinct from a community-based provider, a community-based behavioral health provider who comes into the school to deliver a service and then bills under their NPI. Both of those things happen in schools, and we want to see all of those models succeed and have more money. But all of my remarks are very, very narrowly targeted to this district employed provider piece. That's the official school-based Medicaid program as CMS runs it. And so we're talking about only one way of funding student health services. When we talk a little bit more about implementation at the end of my remarks, I think I want a strategy that I like, and I think is extremely impactful, and we've seen work extremely well in other states, is to move expansions in both and remove barriers to both the school-based Medicaid program and other student health services through Medicaid in schools. And I would encourage thinking about this as a both and model. But again, what I'm talking about, and the super nerdy technical things that I'll go through are just about this. And I think that's really important. So we are just in the right bucket. I also want to be really clear that I am acknowledging the challenges with the workforce, particularly in Alaska, particularly in rural and tribal districts. I understand that there is a workforce shortage, and I'm not glossing that over. We can talk separately about workforce, but for the purposes of this conversation, we're looking for retroactive reimbursement for the bodies that are already in the seats. And so because Medicaid pays back billed services, we're really talking about getting reimbursement in for the providers who are already there delivering services. And then that money comes in to supplement, not to supplant any additional funding, not existing funding, but to supplement the school health budget. So this is not a new funding stream for new providers. It's acknowledging the important role of the providers who are already in the school, already seeing these kiddos and billing for those services. So I know that's a lot. I've just thrown a lot about who I'm talking about and what this is, but I think it's important to remember that too, that this is about the school nurses, the school psychs who are already there and billing for those services. And again, bringing in more money to supplement that student health budget, which it's worth saying, as the ESSER money goes away, as the COVID relief dollars go away, as state budgets constrict, finding new and sustainable ways to reimburse those providers for their time, I think becomes even more important going forward. Because investing in school Medicaid really does bring in more money for student health services. And it has the potential to bring in additional resources, which would allow in time schools to cover more services, to invest in more providers, to potentially expand the workforce eligible for reimbursement. Again, the bodies who are already there, but allowing more types of providers to bill in a school setting. And by bringing in these sustainable funding sources, really doubling down on that connection between how health outcomes impact academic outcomes and investing in that whole child approach to this work. So with all of that preface, let's get down to the nuts and bolts of what Medicaid can pay for. Medicaid, state Medicaid, can pay for a student health service in a school setting if the student is enrolled in Medicaid, if the services are in the state plan, if the provider is a qualified provider that is recognized as part of the state plan, and the appropriate billing, documentation, and oversight processes are in place. In other words, to sum this up, again, Medicaid can be Medicaid for a student in a school setting. And if the student is enrolled and it's a qualified provider, you can bill for the time that provider spends delivering an eligible and covered service in the school setting. This is a slide with a lot of words. I'm not a particularly visual person. I like a lot of words. And as Teresa and Jen said, we'll send these slides around so you could spend more time mulling this at some point. But this is the type of physical health services that are generally covered in schools and could generally be covered in a school Medicaid program. And these are the types of mental health services that are coverable in a school Medicaid program. These are just examples of the type of services that we see covered in a state plan in a school setting. I'm going to flip back. I hope it doesn't make anyone dizzy, but you can see it's a pretty wide range of services and a pretty wide range of different types of providers who can deliver these services. So thinking holistically then, by expanding the number of kids who you can bill for and expanding the services and expanding the type of providers you can bill for, that's a lot of new money that you could find and leverage to bring in from the federal government back into the state and then into the school districts. So the reason we're having this conversation and the reason for that whole setup is the school Medicaid program had actually been operating under a 20-plus-year-old guidance and was pretty out of date. And then in May of this year, for many just really exciting reasons, not the least of which is so many of you have been advocating for improved student health, CMS, the agency that runs the Medicaid program, released new guidance about how the program needs to operate. And it's a pretty great document. It's long. I don't know that anybody's going to want to read it on its merits, but it's got some great stuff in it that really acknowledges the role that schools play in healthcare outcomes and that Medicaid plays in supporting student health. Importantly, though, the guide puts out new rules for school Medicaid. It promotes the approach I've just been talking about expanding school Medicaid to really leverage the federal funds. And it provides new state options to reduce the administrative barriers and burdens that schools and providers face in participating in the program. But these are state choices. The federal guidelines are just that, guidelines. It's a roadmap of the world of the possible and what you can do. There are things that states will have to conform with, and states have until 2026 to make sure their programs align with some of the more nuanced parts of the rules. But also, it gives states choices on how they can proceed. And that's really what this whole workshop is about. What choices can Alaska make to leverage this new guidance to make it what works for your schools? And so the guidance lays out these choices for the states and does encourage states to take advantage of them. States, though, will have to submit a state plan amendment in order to get the changes approved. And some of it can be done regulatorily in terms of implementation. Others can take more guidance related options, but for the most part, a state plan amendment will be required to make big changes to your school Medicaid program. And most states, and I would go ahead and argue all states, will need to upgrade their program in some way in order to be in compliance, to conform with the new guide. So it suggests to me that all states will be moving in the direction soon. Changes to the school Medicaid program do take a variety of different approaches. And we'll talk about them a little bit more. And I have lots of examples we can dive into if it's helpful, but they can be extremely narrow changes. For example, Kentucky just changed their state plan amendment by striking out the word IEP in order to ensure that all students could bill. It was the simplest state plan amendment I've ever seen. But most states take a much more comprehensive approach and really expand and strengthen and invest in different types of providers, different scenarios to really address what the schools need in order to operationalize their program. And many states have taken advantage. This is sort of maybe the inspirational part of my presentation, that states really are moving in this direction. This is not a brand new phenomenon. States have been inching towards expansion for a long time. And what I think the Bipartisan Safer Communities Act that Congress passed 2 years ago, and then this new guide did, was set states on a path of action. 25 states, so half the states, have done something to expand school Medicaid. And now all states have that opportunity, and there's no question that that's what the guidance says. But all states have done something. 25 states have done something, even if they don't look the same. So these are the states that have taken action on school Medicaid to expand outside of the IEP and to cover more students. As I said, this is a range and represents a lot of different things. But you can see it's red states and blue states, it's rural states and urban states, it's southern states, it's Midwestern states. It really is a range of states. The states with the asterisks are those that CMS counts. I'm in a little bit of a narrative fight with CMS. My count is more than theirs. These states are the ones that have taken state plan amendments. Other states, those with the asterisks are not counted by CMS. These have taken administrative actions, regulatory actions, and these have all put in state plan amendments. But this is what it looks like on a map. And again, they vary in scope and quality, but really it shows the movement behind this. And here's how states have done this. They have expanded their school Medicaid program in kind of one of three buckets. The first, and to me, the gold standard, is that they have expanded school Medicaid to cover all services to all Medicaid enrolled students. And it would be all medically necessary services because that's Medicaid's requirement. But it is the most expansive of the ways to expand. And it really helps ensure that if a provider delivers that service to that Medicaid enrolled kid, it is a billable service. It doesn't require anyone to do it, but if they choose to bill, they can bill for those services. And Michigan, Virginia, Illinois, New Mexico, Nevada have all taken this approach. Then a set of states have taken a comprehensive but defined benefit package. So they cover a lot of services, but maybe not all services. So for example, Massachusetts and California have a specific services list. It's really comprehensive. Candidly, I can't think of any service that wouldn't be covered, but it is not as broad as covering all medically necessary services. And then finally, a cohort of states have expanded to cover specific services and or specific students. So some states like Connecticut and Indiana cover students with 504s, but that's it. Still an extremely important population to cover. They cover the health services in a 504, but it is not as comprehensive as covering all Medicaid enrolled students. Also, some states, and I think a lot of states are looking at this, have expanded to only cover nursing services in a school or to only cover behavioral health services in a school. Again, less comprehensive than all services, but it does increase the billing that comes to the schools. In each of these scenarios, no state is done. It is a spectrum. And so it is important to think about this as a sequential path, and you can take steps along the road. And all states have opportunities to continue moving forward. And that brings me to sort of the last thing I want to say here is getting the state plan amendment right is only the first step of the journey. Implementation is a big part of this. And implementation, I would argue, begins even before making the policy changes. What I have seen across states is successful implementation in the end involves partnership, coordination, and building a really big table from the beginning, designing an expansion and designing the change, including everyone from the beginning. And I think I'm particularly excited about the mix of people on this call because I think it really fits that. It helps if the Medicaid agency, in partnership with the state education agency, issue clear, transparent guidelines to the LEAs and to the providers. I know we have some state education agency folks here, and I've worked with some folks in your state to really think about how to do that and how to be clear. That's a big part of success. Similarly, thinking about staging reductions in the administrative burden, including on documentation for providers in the school setting. I know those are challenges and they are fairly common, but common across the Medicaid program. But clear guidance, along with a deliberate attempt to address the administrative burden, has really paid off in a lot of states. And there are ways to mitigate that burden, including through CMS's new guidance. And finally, ongoing technical assistance and regular training to school districts and providers is a big part of that story. I'm going to stop there so that I still have a little time for questions. I did a lot, but I think the thing I want to leave you with the most is that expanding and investing in school Medicaid is consistent with federal guidance. In fact, they really are encouraging states to figure out the best way to structure school Medicaid programs going forward. That implementation really, that success includes partnership across all the child serving agencies and the school serving agencies in coordination, and a real focus on clear, consistent guidelines to help providers through this. Okay, let me stop abruptly because otherwise I'll just keep talking. And now I can see the chat, I can look, but Jen or Teresa, any questions, anything that has come up so far, or anything you'd like me to expand on right now?
Yeah, no, thank you so much, Lena. That was very helpful. No questions in the chat. I will just note that we dropped in the CMS guidance and then a couple of documents that Lena referenced and what she was sharing kind of specific to that guidance that kind of provides some analysis and some support. So those are there for your reference. Does anybody have any questions? We have about 10 minutes. If there are questions for Lena, or we can just have, if you have, yeah, go ahead.
There is a question in the chat. Which I will address. So in case anyone can't see the chat, let me read it. Or summarize it, that I glibly use the term retroactive reimbursements. Let me address that, and then I'll get to the second part of the question, because Tennessee did something interesting on timely filing, which I'll talk to. I use that retroactive reimbursement as a way to really distinguish from grant funding, Paul. And it is just me using it glibly, but I think it helps people who are not familiar with Medicaid understand that Medicaid reimburses for a service that has previously been delivered, as opposed to getting a grant and standing up a program where your money is front-loaded. And I think that's an important distinction when thinking about how money flows into the state and how it supplements state budgets in a way that is not meant to replace it, but also is really tied to the specific delivery of services, as opposed to grants to stand up workforce. So it is not in any way a Medicaid term, but I find it a helpful way to frame the difference between Medicaid funding and grant funding. You can't get paid back for Medicaid unless you've actually delivered that service. That said, your timely filing question, Tennessee did do some, I'd have to look it up. And as I've already previously mentioned, I'm a bad multitasker, but Tennessee did change the timely filing requirements in their school Medicaid program to allow for some of the challenges with documentation and billing. Their program is interesting because it is all through managed care, which adds a different layer of complexity because they have to bill 3 different managed care companies. But they were able to work it out in such a way that the schools had a longer timely filing period, which really helped them if not reduce the administrative burden, sort of smooth it out over a time period. So if timely filing is an issue, I think there's some clever ways that are permissible under the Medicaid rules to address that. I hope that helps and answered that question.
Yeah, I said one follow-up. Is it okay if I ask verbally?
Yeah, go right ahead.
I vastly prefer that.
Yeah. So are you suggesting that when maybe bringing on new services into the SPA that you put in language that says like, hey, for this new service or any expanded new service that wasn't recently covered, could be billed at a different timely filing than others for a period of time or something like that, or you think that's too aggressive?
I mean, I'm kind of in favor of an aggressive approach to leveraging school Medicaid, but I don't know if it's permissible. We'd have to really think that through, and it would be so a lot specific. I don't feel I can comment on it.
Okay.
However, I'm going to use your question to say something else that I would like to say, which is not directly an answer to your question, but I think it's important to say. One thing states have been doing is expanding the types of services and providers in the school system. And it's a nice first step in thinking about what's really being delivered. And it's one of the things I've really valued about working with some of your colleagues in the ed department. It's looking at who's already in the schools. What types of providers does the school already have? Who is there? What bodies are in the school? What services are they delivering? And doing that crosswalk between what is already being delivered in the school and what is covered by the state plan has often shown some disparities of types of services or providers who can be billed. And one great example, or one of the biggest gaps, are the behavioral health providers, and in particular, the school psychologists often aren't billable under the school plan, under the state plan in schools. And by making that change, sorry, I was going to actually I managed to close out my cheat sheet of I'll send this around. We have the financial impacts that have been self-reported by states who have expanded services to school psychs. And like Michigan, in the first year of expanding to cover school psychologists as a qualified provider, brought in something like $15 million in the first 2 years of totally new federal funds. So it's real money by looking at that. And that worked for Michigan. By looking at the types of providers and the services and doing a thoughtful crosswalk, you can often identify those gaps in services and providers and think about how to fill those gaps.
Is there any chance you could show that slide on the journey that you was like the second to last slide you had? Like, I actually thought that was really helpful for hey, it can do different steps to get there.
Yeah. No, Paul, I can't, because I shut them down, and there's simply no way I will be able to pull them up.
Okay. I can circle up with some of that.
I really wish I were less of a Luddite and I could quickly solve that problem, but there's simply no way in the 2 minutes I have remaining to pull that back up.
No
but
problem.
I will share my slides, and what I'll do is I'll drop in some of the other some of this financial impact stuff, so you can see that at a later date.
Yeah, I thought it was a great slide to share to stakeholders, like, where are we on that journey, in the state of Alaska or whatever state you're in, is, hey, we're here, or a little bit to the left, a little bit to the right, and here's the next step. It might be a nice way to summarize the challenge quickly.
Well, and I think it is important to think of this as a journey. Even the states that expanded early have really they keep coming back to strengthen and improve and to help their providers. I mean, my favorite example of that is Louisiana was the very first state in 2014 to amend their program to cover school nursing services. And it was so successful, they came back and got a spot to cover all services in the school, all EPSDT services in a school, like 3 years later. And they're back again now to continue to think about additional investments that would make the program work better for their schools. So I do think that continuum journey is a good one to think through. And I'll happily share the slide at another time.
Yeah, and we'll send that out, Paul, in the follow-up email too. We'll send out Lena's slides, so you'll have access to that. Lena, there's one more question in the chat from Jennifer. Do you see that one?
Oh, I do. I do have comment on that, but I'm not sure I'm particularly qualified to comment on it. I will say, so take my take my remarks as just my opinion. The telehealth has really expanded the reach of providers and thinking about linguistically and culturally appropriate and relevant services and the ability to deliver services in that way, particularly for behavioral health services. I think we've seen states make great achievements. I think it has worked really differently in every school district in terms of independent external providers and school-based providers. I will say it works best in partnership. The school to do effective telehealth services in schools really requires both a school-based component and obviously an external component. That partnership and how that's defined and how that's managed and what that MOU looks like is really interesting. Oregon, they're a little dated now, but I will just reference Oregon during the pandemic did this just awesome toolkit about how Medicaid would pay for different telehealth services for different types of school-based providers so that they knew how to bill. And it didn't matter if the service was being delivered by a community-based provider or a school-based provider. They put out guidance that was said, you know, if you're doing a virtual nursing service, you know, here's how we will pay for it in a school setting. And I've always thought that toolkit model was pretty excellent. Again, it's dated. It was really pandemic specific, but it's still one of the best examples I've seen of the tele and mobile health partnerships. I could dig it up if it's helpful. Again, not directly applicable at this moment, but I think a good guide. And again, it sort of circles back on that. It's just the clearer and more transparent the guidance is, the easier it is to follow, and the more you can build the appropriate partnerships. The last thing I'll say on the telehealth thing is other people have written a lot about it, and I defer to the experiences of every school district about how it would work in this state. I think that's your best example of where you could find that. But a lot of people have started writing about it at the national level. I am just not in any way the expert in that. And yeah, I'll pull up that Oregon stuff. I have it somewhere.
Yeah, thanks, Lena.
Not now.
And then Sarah, there's another question in the chat from Sarah, and then we'll pivot to our next presentation.
Oh, yeah. Most states don't cover those. Sorry, the question for those of you who can't see it is about orientation and mobility or teacher visually impaired as Medicaid providers in school settings. I mean, my short answer, Sarah, is, I mean, that's a whole it's a whole thing. But that's fundamentally what I'm talking about thinking about what types of services and providers. What Texas has is pretty unique. And I don't know if there are other states that cover them, but Virginia, for example, covers some personal care services in a way that I've never seen any other state cover. So states choose to invest in the types of providers, I mean, kind of at the most basic level, who are at the table to advocate that they are included. I think it's why an important and big table is helpful in designing this and inclusive of providers and school districts who really know what they are doing it. I encourage that conversation at a high level. I will also say, and I can do this one for sure as soon as I get off, or as soon as I stop talking. We have on our website, it's a little dated, so it needs to be updated, and I acknowledge that. But we have a really cool state-by-state guide of what's covered in state plans. You can kind of poke around and see what other states cover. If one state has covered it, it is likely coverable in another state. And it's thinking about how you do that and what needs to happen in your state Medicaid plan to get that done. So it's sort of interesting to think about. Sarah, I'd be happy to talk more about how Texas got some of their stuff done. Texas is a little wacky in how they manage to cover things. But I think they're good examples there too. I'm over, I know.
Thank you so much. Oh, no, you're great, Lena. Thank you so much. And guys, thank you for the questions. I mean, that's what we're hoping. We know this is really presentation focused and there won't be we haven't built in a ton of time for questions, but we appreciate the engagement. And there will be a post-event survey where you can let us know what other questions you have, right? And more opportunities to discuss. So we'll keep this conversation going. Okay, so we're going to pivot to a statewide perspective and kind of focusing on some current strategies that Alaska schools are utilizing, specifically related to mental health. So Eric Boyer from Alaska Mental Health Trust Authority and Pat Sidmore from DEED are going to share with us about the mental health in schools reports. And either we'll drop the links to in chat for those reports as well, for those of you that don't have access to those. So Eric and Pat, thanks for being here.
Thanks, Jen. Again, thanks to you and your team there at the Children's Trust for bringing this all together. I keep looking at the participant list. It's an awesome group that we have on today. Thanks, Lena, for your presentation, kind of giving us the overview of what other states are doing. That's always kind of a good measuring stick and roadmap for us here in Alaska. And I'm going to give the bulk of the time to Pat because he's the expert on these reports, because he was a part of the leadership planning team that worked with the Stellar Group to put the mental health supports in Alaska schools reports together. The first was a phase 1 that came out in 2021 in the summer, so just a little over 2 years ago. That was a landscape analysis, really detailing what mental health supports look like across Alaska school districts. That kind of gave the basis and foundation for the phase 2 report that Pat will review with all of you. And that really was building on kind of the promising approaches that we're seeing across Alaska. It's built around a series of case studies of how those promising practices have been developed, what we're seeing. And I think it'll really kind of help us, as you mentioned, Jen, kind of having a baseline as we look at the challenges facing us here in Alaska and with our youth and children in schools. So again, I want to thank Pat, and I also want to thank Jamel Johnson. She would have been here today doing this part, but some of you probably already know Jamel is transitioning to a position at the Rasmussen Foundation. So she's no longer with the trust, but we sure appreciate the 6 years that she worked here and really helped the trust and our partners establish prevention, early intervention with our children and families as a priority for the trust. And with that said, Pat, I want to give you time for some detailing of the phase 2 and then being able to address any questions we have. All right, Pat's pulling up the PowerPoint. We can see it just fine. Thanks. I'll pass it over.
Sorry, let me try that again. Hi, everyone. Can you see my screen? Is it all right? So I'm going to go through a little bit about the behavioral health scan that Eric talked about, and we worked with Jamel and a whole group of folks. I'm going to go through my obligatory Department of Ed slides here at the beginning. This is our mission, vision, and purpose here at the department. I'll let you go ahead and take a look at that. And I just want to talk about Governor Walker put together a group of Alaskans that came up with an educational challenge, and they came up with 5 precepts that we really wanted to focus on. I would say reading is now really added to that, but number 5 is where this work resides: improve the safety and well-being of students through school partnerships with families, communities, and tribes. And this is that specific challenge. And there were 3 strategies: create sustainable and positive school climates, build trauma-engaged schools, and increase students' access to counselors, nurses, and school social workers, which is a part of what we're going to talk about. As Eric mentioned, a group of us started this work back in 2019 before the pandemic. It really sprang from, we had been meeting together. Jamel Johnson from the Trust brought us together, but we've really been meeting together for years. And it was a partnership between public health, the Department of Education and Early Development, behavioral health, the mental health boards and advisory board on alcoholism and drug abuse, and others. And we there was legislation around this idea of mental health in schools, and there was really a lack of understanding from some of the advocates about what was happening in schools. And we knew there was an amazing amount of work happening in schools around the topic of behavioral health. But we didn't have it really documented in one place. And so the Mental Health Trust funded us to work with the Stellar Group, and you saw the reports that are in the chat, and I'll talk a little bit more about them. But this is kind of the timeline that we worked through. And so the final phase came out in the summer of 22, and I'll talk a little bit about what we've done with that information so far, and then what the plan is moving forward. But it ties in, I think, and informs this discussion of Medicaid in a way that I think is important, especially around the in the area of behavioral health in schools. And I think this is the first thing that's really important. As someone who's new to the Department of Ed, just over a year, but having worked with them for years, I like to say I speak education with an accent. I'm a mental health clinician by training. And so kind of bridging those two worlds, it's really important. And this model, the multi-tiered system of support, is how schools think about both academics and behavioral health or health issues. And there are 3 tiers. Universal, they're down at the bottom. That's the things that we do for everyone. Targeted support for kids that have risk factors. And then finally, intensive supports. And so I think when we think about Medicaid, primarily we're talking about tier 3, those intensive supports, but I think there might be some opportunities and to think about Medicaid as maybe a tier 2 intervention as well. But this is a framework that schools understand, and I think it's like the public health model of prevention. It's really handy way to think about it. And we framed our research through that model. The phase 1 research came out, and it's in the chat. And what we did was we interviewed 32 districts. And there, just so you know, there are 54 in the state. Those 32 districts represented about 95% of the students that go to public education, K-12 public education in our state. And we looked at 5 areas. What mental health concerns do they have? What foundational elements are in place? What mental health supports are in place? What impact and barriers are there to that? And what's their ideal system? And then out of that came a summary report. And I think the key findings were this, that all districts were tackling this issue in some form or another. It was a combination of their internal resources and external resources based on what their community offered, and whether it be through tribal entities or community behavioral health agencies, everyone had some sort of partnership with different entities in their communities, but it varied widely, as you might guess. Oops. Did I just repeat? Oh yeah, let me try that again. There we go. So the community partnerships, each district really came to the conclusion that there needed to be a lot of training of school staff and community partners to provide this any sort of support in the schools. Again, we see this even in individual districts, where even one school in a district will have a relationship with the community behavioral health provider that really is working, and another school district down the road doesn't. And so trying to really figure out what's going on with that and systemically is, I think, part of the work that we have to do. And I think that I think that, you know, I know there's work going on right now across the state with the Department of Health, going into communities and asking about the whole range of community behavioral health treatment for youth. I think it's important. Schools are not always at those meetings. I mean, we try to let them know, but I think you all understand that schools are what I like to call a place of hair on fire. They are dealing regularly with a lot, and so getting to those meetings is sometimes difficult in different communities, and the voices aren't always universal. So I think that's really important that any sort of effort moving forward around Medicaid or any sort of behavioral health issues moving forward really helps. It would help to bring in the Department of Education. I'm going to talk a little bit about our team. I appreciated, Lena, you talking about how in other states this partnership between the Department of Health or whatever that entity is in other states like ours and the Department of Education is crucial. Just so you know, our team that does health and safety, all things health and safety, all kinds of health, emergency preparedness, everything is 3 permanent positions and 1 non-permanent position. So in terms of capacity, at least on our side, there's not a lot there to expand, but we've been following the national discussions on Medicaid. I have a history in Medicaid policy, so I have some understanding of it. But again, that is a small sliver of what we're doing. So any sort of work moving forward really needs to think about capacity at the state level, I think, in both departments, if there are efforts to move this forward. I wanted to talk a little bit about those districts, those individual districts. I'm going to show you what those reports look like. I'm going to pick a district out and show you what it looks like. But I want you to know that if you're from any of these districts and want your local results, the link is there. You can go check out it's I don't know, 3 to 5 pages of results from each district. And I'll give you an example so you can see what's there. You can go look and see how different it is if you want to cross tab between different districts, and look at the resources and how districts are approaching the issues. So I chose Fairbanks because it has an interesting point that I think that feeds into this discussion. So this is what they have. They have 10,000 students. So this is one of our big districts. And it's a busy slide, but there's I think data is a really important piece. You know, they're looking at culture, which I think is a really important piece. The family outreach, that we've got several efforts, and I'm going to talk about that later, about family and how that's gonna play a role in this. Anyway, I'm going to start here, but I want to show you what that slide looks like. So there are really 2 things. I talked about the multi-tiered system of support. Remember, tier 1 is that universal, and these are the things that when our contractor interviewed Fairbanks, these are the programs that they have in place around tier 1. So sources of strength, the suicide prevention program, 4th R, that relates to healthy relationships, safe dates. This is how they're meeting the Safe Children's Act portion of Breeze Law portion. So you can see how that those lists, and then who is delivering those teachers and counselors. Okay. And I want to point out that in many of our districts or in many of our schools, we don't have school counselors, or for that matter, I know my colleagues from public health are on many schools. Most schools don't have a school nurse. So we've got to think about that as we expand or think about expanding services. Then tier 2, some other programs, you'll see some overlap with tier 1, and where that how that's being administered. Project Aware, which is a grant that I'm going to talk about that they have. So those are school counselors. Those are finding those kids that are potentially at risk and serving those. And again, you'll see at the bottom grant funds for both of these. That title means the Education and Secondary or Elementary and Secondary Education Act funds. So you might hear Title I schools or Title 4A, which I administer. They may be using funds for some of that work there. And then finally, the one that most relates to what we're talking about are tier 3, individual counseling, de-escalation, school psychologists. There was discussion about that. And you'll see right in the middle there, AK Rises, Mental Health Clinicians, and Project Aware. So the department right now has 2 federal grants. One is through SAMHSA, and the other is through the Department of Education, that provide mental health clinicians to different schools in the Fairbanks system. It's kind of a unique little experiment in a district having 2 different methods of what this looks like. AK Rises, excuse me, has mental health clinicians that are external to the school, and they're working with Anchorage Behavioral Health, the trauma center, and they provide clinicians in the school. Project Aware pays for clinicians. I'm sorry, AK Rises outside the school. Project Aware clinicians in the school, where we're doing that. And I think there's some interesting results and discussions to be had about how that's worked. Again, it's all grant funded money. So thinking long term, I understand the Medicaid piece, but the Medicaid piece also, of course, adds administrative burden as well that we have to think about. So I just wanted to point this out because I think we've got some examples, and my colleague Sharon Fischel, who manages both those grants directly, I think has some unique insight into those 2 different models, external and internal clinicians. I don't know if there are any questions in the chat at this point. I can take a little breather.
No questions in
right.
the chat right now, Pat,
okay.
So.
Then we did a second wave, as Eric mentioned. We did a second wave, and this is where we honed in a little bit more on individual districts and did a little bit more detail. And we looked at 6 districts, rural and urban, small and big. And so I'm gonna hone in actually on a small district, Cuspic, which is at the top. And what we found from Cuspic was really fascinating, and this gets to Jen Moreau's question earlier when she asked Lena about telehealth. So Cuspic has gone in, I think they're in year 3 or 4 of a contract with a telehealth provider out of state, where they're using some ESSA money, some elementary and secondary education funds, to pay for a therapist to do telehealth with their clinician or with their kids. It's been really successful. They've had the same clinician that whole time. That she has been to the district now, as trained staff as well. But this telehealth piece in rural districts has really sort of taken off a little bit. And that's partially what we've done as we've taken this out around the state, is highlighted different things and pointed people to the report. And there are now other rural districts that are doing similar things where they're contracting with a telehealth provider to capture seats or hours of therapy that for their students, because that's really the only way they can get those tier 3 counseling services into their school. Like I said, this is a 3-year 4-year effort at this point. The superintendent's really happy with it. The other districts are just really starting it. So I think that that's an interesting thing to think about, especially as we think about funding sources moving forward, whether to stay with the funding sources they have, which may have less administrative burden than Medicaid. But this is a good rural example of how one district has broached that tier 3 issue that they were struggling with. The other thing is, again, I just want to talk a little bit about some basic things around what's going on with mental health from our department. Of course, we have the trauma engaged schoolwork. And if you're not familiar with this, there's a link there. This has been recognized around the country and frankly, internationally. The Chicago School District has modeled a program off of this work. There are 2 research projects, one funded or both funded by the U.S. Department of Ed on this framework in different school districts across the state. Several state entities school districts have really embraced this model. I want to talk about some of the other efforts that we have around behavioral health. I mentioned AK Rises and Aware. AK Rises is in Fairbanks, and so is Aware, but Aware is also in Bering Strait School District and Juneau. Clinicians in the school there. That's both of those are 5-year grants. The our behavioral health helps to fund our trauma engaged alternative schools. Alternative schools are in our state where kids who have struggled in the traditional K-12 high schools, in some cases middle schools, have a place to go. Very supportive of behavioral health issues, anxiety and other things, depression. We have a suicide awareness prevention in schools grant. In fact, they're meeting Wednesday in Anchorage. That's funded by the State Suicide Prevention Council. I don't know, a dozen districts or so have that. We have funded through Eric's team at the Mental Health Trust, a rural school counselor that supports rural schools who don't have counselors and some who do, really trying to boost those areas up. Also working with our partners at AASB on one of the trauma engaged school practices. The feds came out with a grant as part of Title 4A, the Stronger Connections grant. We have $4.5 million out over the next 3 years to 9 districts, most of whom really chose a behavioral health focus, counselors, peer mentoring. And then we have a positive behavioral intervention and support grant out with COVID funding that again supports staff. So all this is happening within the context. So it's really important, I think, as we think about Medicaid and we think about resources towards it, that how do we sustain what we have, or and how do we adapt new practices. Couple other things, and then I'll be available for questions. I mentioned one of our trauma engaged school research projects. It's with the Northwest Regional Education Lab. We're in year 2 of that. We surveyed all the schools about how they're using the trauma engaged school framework. We got about 300 responses of the 500 schools. We're looking at that data and their administrative data and their school climate data, and we'll hopefully start getting those results soon. We're working with the University of Washington and Seattle Children's to support rural itinerant counselors, those people that are out there moving from village to village, and they're getting now regular virtual support. Our partners at Public Health, the Youth Risk Behavior Survey and the School Health Profiles, we support those both financially and in any other way that we can. We have lost that those data for the youth risk behavior survey. The last year, the last time, we're not sure about whether we're going to have statewide data. That data is crucial for our work. So that's really important. We are regularly doing school health echoes on trafficking, on behavioral health. Those happen every month. The department supports that. Our partners at the Association of Alaska School Boards, I can't say enough about how much work they're doing on family engagement, on trauma-engaged schools, and a host of other things around policy, really building mental health support into all their model policies that local districts can adapt. And I mentioned the Regional Education Lab. They are helping us with a number of efforts with alternative schools. We sit on all these committees or councils in some form or another. So we are engaged with that. And then lastly, I just want to point out that we have an e-learning system. Samantha Wilson on our team manages that. The suicide prevention courses, we have 4 courses. There have been 57,000 of those courses taken by educators. Trauma engaged schools, 18,000 courses taken. Substance misuse, 1,300 courses taken. That includes vaping, opioids, and things like that. And then other behavioral health, which is it includes mandatory reporting. It includes some substance abuse issues as well. 105,000 have taken that course. So we are constantly trying to provide behavioral health and other trainings. This system has over 90 courses, so it's nutrition and everything else as well. But we're constantly trying to promote the knowledge of educators to support the work. And then I'll just leave it with questions.
Thank you so much for that overview. We grounded this in the beginning and just really wanting to, a both and, as Lena said, right? How do we consider this opportunity that we have while also really building on what exists? And so thank you so much for just providing us that context. I want to call out before we open up for questions, the concern about administrative burden. That is something that our team identified early on in this process, especially for smaller school districts. My heart is in rural school districts. That's where I've spent the majority of my adult years prior to our move to Alaska, is in small towns. So that is definitely something we were watching. Lena dropped some links in the chat, and that's something we've talked about in looking at other states. How do they manage that potentially? And then with that, how do we really pull schools into the conversation? And you referenced that, Pat. So those are 2 things that we're really watching, and would love to hear other thoughts on that, especially in the survey. So again, just to highlight, we'll have a post-event survey, and you guys can drop your thoughts and comments related to those or any other kind of thoughts and concerns really moving forward. But I wanted to thank you for bringing that up as well. Does anybody have any questions for Pat or Eric? Okay. Yes. Thank you so much.
Jen?
Yeah, Eric.
Since we have a minute, I just wanted to add in one thing that I think is kind of great presentation, Pat. Thanks for that. Kind of some of the practical steps that, evaluation research into projects like this phase 1, phase 2 really come into play. Dr. Hattie Harvey and others from the University of Alaska Anchorage, along with partners, utilizing this report as a foundational step towards looking at the need for a programmatic at the university level for training school psychologists here in Alaska. That program has not existed. And so because of that, we were able to work with our board at the Mental Health Trust to partner with the university and others to actually fund. It's a 4-year process to stand up that program. Big kudos to Dr. Hattie Harvey and her team there, working with partners at the national and state level to stand up that program. It's being put together. It's being operationalized as we speak. And then in July FY25, we'll start the second year of funding, where it'll really start looking at the programmatic classes, core curriculum, starting to look at faculty, and I think within 3 or 4 years we'll see the first cohorts going. So it's a process, but one that we needed to jump into, and we needed that evaluation, what the data is showing, best practices to be able to move into that. So really exciting stuff, and couldn't be done without a lot of the people on this call and really partnering together.
Eric, that's great news, and it does connect back to a link that I think Melissa dropped into the chat, specific to school psychologists and what Alaska code says about how they can bill. I just want to point out that that is the challenge that we face in Alaska. That is the first challenge that we face in expanding the ability of school staff to be able to bill for Medicaid services in our statute. And I can find it and drop the link in during the next presentation. But in our statute, it is limited to IEP services. So even though CMS allows it, unless we have a change in that statute, we can't move forward with billing. So that's kind of the first piece that's been identified. And I think that, the being able to provide support for a school psych program, that's expanding that Medicaid and that billing piece, that's key. Being able to kind of go beyond IEP to all students with Medicaid could really provide some support for that moving forward.
Jen, that reminded me the other thing that the department, and I appreciate Eric and the trust funding the school psych. We're working with them a little bit on that to support it, but also working with the school social work to help streamline that, and they have an effort to expand the number of people in that, which the people can come out at a clinical level, which is exciting. The other thing I didn't mention about the behavioral health scan is we did survey whether or not there was any billing for behavioral health services by school districts, and there was not. So just that's important.
Yeah, that is important. Absolutely. Thanks for sharing that. Okay, I appreciate, just again, thanks for sharing comments and dropping links and sharing that in the chat. That's really helpful. We're going to conclude with our final presentation. Joe Weber and Rich Albertoni from Public Consulting Group are going to share about the Alaska Medicaid Strategy Report, which included some recommendations on school-based Medicaid services. So Joe and Rich, thank you so much for being here with us and just for taking the time to share.
Great, and I'll go ahead and pull slides up now. We get started. I also want to mention we are also joined by another colleague, Peter Gillis, with us this hour. I can officially say afternoon now to everyone. Now that we've passed the 12 o'clock hour locally for everyone in Alaska. So thanks again to everyone for being part of this conversation today. I think we just wanted to, as Jen mentioned, we produced a report. It's a little bit dated now. It was produced originally back in 2021. But one of the key takeaways on that was around school-based services and under Medicaid and opportunities to expand and increase reimbursement for those important services. So just before we kind of jump into that, just to give you a sense of PCG and kind of where we're at, where we're kind of coming from in this intersection is, so we are a national, international consulting organization. We're based out of Boston. I'm personally out of upstate New York, but we do have offices across the US and Canada and even some still in Europe. And we've got a team of over 2,000 staff covering a wide range of areas of expertise. In particular, we cover 4 main areas, from human services to technology consulting, and I think most germane to this conversation for myself and Rich and Peter in the health and education space. So really in that intersection of where school-based services, delivering school-based healthcare services intersect with Medicaid. And that's one of the things that I think is a challenge, everyone that works in this space is consistently dealing with is that dynamic where you're trying to serve a student and everyone is coming at it from the educational perspective, but then Medicaid has these set of rules that don't always work very well and play very well from the healthcare side, that they're overlaying into the education side. And so a lot of the conversation about what clinicians can and can't do, what can be billed, what can't be billed, is all very familiar topics that we've worked through in a number of states on our side. And so just to, before we jump into the report, contextualize this a bit further. So right now we're currently working with 16 different states across the country on statewide school-based Medicaid projects. And so that encompasses the fee-for-service, direct service aspects of it. It includes Medicaid administrative claiming elements of it. Most of these states are under a cost-based reimbursement methodology that leverage a certified public expenditure funding mechanism, which we can talk about a little bit more once we get into the report. But this just gives you a sense of kind of where we're coming from, that we do when we made this recommendation around the school-based program and the conversations we've had since, that we do kind of bring, similar to what Lena spoke to in her presentation, bit of a national perspective, a sense of what other states are doing in this area to really kind of, I think, optimize reimbursement, but also be as inclusive, as expansive as possible in the delivery of services to be able to serve as many students in the school-based arena as possible. So with that, I'm going to turn it over to my colleague, Rich Albertoni, and Rich was the lead for PCG when we conducted the Medicaid strategy report, and apologize. We know at the time we wrote the report, it was the single agency of DHHS or DHSS. We know that in the interim that there's been a split, and it's now the Department of Health, or DOH, is the single state agency responsible for Medicaid. So we did leave the DHSS nomenclature in here, as that was at the time how our client and the main audience for our report. So Rich.
Yeah, so good afternoon, everyone. Rich Albertoni. I'm talking to you today from Madison, Wisconsin. And just a little bit about me. Before I joined PCG, I worked for Wisconsin Department of Health Services, and I was in the Medicaid program. And I actually did have responsibility for the school-based service programs for Wisconsin during those years. So I do have some pretty good technical familiarity with those programs. But I just want to start with a little bit of context for how our work on school-based services arose. And that is as part of a study that we were hired to complete on behalf of then DHSS. And the RFP for that work came out in 2019. And it was very much a Medicaid-focused strategy study. You can see in the top half of this slide specific language that came out of the RFP for the study. And, I would just say in general, the study was focused on cost containment principles, on how to improve care while trying to be cost efficient. And then for sure, trying to take into account features that are unique to Alaska and the Alaska delivery system, including the tribal health system and the unique rural nature of the state of Alaska. So the plan was for me to spend a lot of time in the state of Alaska doing stakeholder outreach. And I did begin that in October of 2019 and was going to make monthly trips up, which I did in October, November, January, and February. And then, of course, in March of 2020, that came to a screeching halt. And the study did end up taking a little bit longer because of COVID. And the stakeholder engagement became like this today, virtual. virtual settings for it. What we did try to do in the study is to basically develop guiding principles that would get us to recommendations and initiatives. And you can see those guiding principles at the bottom half of this slide, really focused on trying to move the delivery system some steps away from fee-for-service without, obviously knowing that commercial managed care has its own unique characteristics, and that Alaska has a lot of unique features that are challenging for managed care. So we just looked at what we could do to take steps forward in that environment. A lot of focus on cost containment and state financial stewardship, and that was some of the thinking around the school-based services. And Joe, I think we can go to the next slide for that. So, yeah, there we go. So just a little bit on this, we did end up putting together a package of initiatives, specific recommendations. There were 5 major recommendations, and they had a positive fiscal impact on the state of about $46 million in state funds. And we did put forward the report in September of 21, and it became something that was available to the state during the budget cycle, early 22. A lot of the agency and legislative considerations as part of the budget cycle. The Medicaid school-based was included in this as one reform principle, and that was really in support of that state financial stewardship guiding principle and the idea that you can improve care for kids and assure that Alaska is claiming all federal money for which it has a right to claim, because our analysis concluded that Alaska is basically leaving federal money on the table when it comes to school-based services. Okay, Joe, next slide. All right, so we did, during that window, these numbers will be different today, but during that window, we did look at state expenditures today on Medicaid reimbursement for the services that are eligible to be reimbursed today. And by the way, the PCG report is online. We can repost it, but it is on the DOH website. So we can get the link to that. And so basically what this slide shows is that our national experience from being in all the states that we're in is that when states move from a fee schedule, which is basically what Alaska has today, in the Alaska state plan, the Medicaid state plan, there is a specific fee amount for rehabilitative services, specific to things like PT, OT, speech, hearing services that are specific to an IEP. And there's a fee that the state will pay for those services that is set. One thing that is true about any Medicaid service that is provided by a public entity, a public provider, so that could be a school district, that could be a public hospital, is that that public entity, according to Medicaid finance rules, is eligible for cost-based reimbursement. And so the theory is that as a legal sub-entity of the state, the cost, as long as it's Medicaid eligible, is already the local match of Medicaid funding. And as long as a state can document that it's consistent with what's allowable under federal Medicaid rules, that the state is eligible to claim up to cost. And so wherever we see states moving from a fee schedule to a cost-based reimbursement or some sort of a cost proxy, generally they increase their reimbursement between 75% and 125%. So we picked the middle, which is basically doubling the revenue that Alaska currently achieves, and saying there would be a positive fiscal impact of about $2.1 million. Also, just a detail that currently the state requires an IGT contribution from a local school entity to basically fund the local share in Alaska of the fee schedule for the reimbursement. All right, we can move on to the next slide, Joe. Okay, and then part of our recommendation too was to consider a broader scope of services beyond just IEP eligible services. And again, we were very mindful of the state law would need changing. You would need a state plan amendment as well. But looking at things like nursing services, even within IEP, there's more opportunity to cover services, just that are specific to children being served with an IEP. So things like personal care, specialized transportation services, that in and of itself could be expanded. Again, just the additional revenue that schools may be spending today that is not reimbursed by Medicaid at all today, but could become eligible and then could draw in federal money to help fund all of this. All right, Joe, next slide.
Yeah, I think just real quick on that too, Rich, and Lena hit on this in her presentation as well, but one of the big shifts, in addition to adding additional services and expanding what's currently covered, one of the other things, and it's probably been the biggest shift in school-based Medicaid of late, has been the idea of Medicaid covering services beyond just that special education population, just the students within IEP, that they are now covering students that it's referred to as the free care rule within Medicaid. For some reason, that's the nomenclature they've chosen. But the idea that you can now, for a student with a 504 plan or a student that has another medical plan of care indicating medical necessity for services, is that those students, those can now be covered. So it's not just an expansion of the covered services, it's broader than that. It's an expansion of the population that you're able to serve and able to impact under the school-based Medicaid program that is historically been limited traditionally to the IEP students only. But now, as Lena said, we've seen a number of states that have taken the opportunity, and CMS is probably, this is a personal opinion, CMS right now at the federal level is probably the most open and willing that I've seen them in my time working in this space, to working with states on expanding access to care and expanding the availability of services in a school-based setting with Medicaid. So.
And Joe, if I could just jump in. So we, as Nina mentioned, Illinois was one of the states that recently expanded their program. We worked with them to update all of their documents, their SPA, they added additional services to both the special education population, and then they also expanded for that free care, that non-IEP population. So they're looking at probably another increase of about another 8 to 12% on top of the dollars that they were already bringing in just for some of those additional services, not to mention some of the expanded populations for licensed professional counselors, their registered behavioral technicians to do ABA services. So it was a complete overhaul of their program. They had not updated their program since the early 2000s and had not looked at their provider type since the late 90s. So it was a complete shift that they were able to get approval for, and are in complete compliance with this new recently CMS guidance, because that came out as they were going through that process.
Yeah, and then so just to close out my part here, so basically we did put in the report a full range of options for the state to consider in innovating its school-based service program, including moving from this intergovernmental transfer to a certified public expenditure or some proxy for cost that basically would help you capture all costs affiliated with providing the care that a district experiences, to go beyond IEP to a greater range of Medicaid services. And then the last item on here is basically to capture Medicaid administrative claiming related to this as well. So what that means is that anything a district is doing to support running a Medicaid school-based service program, not actually providing the covered service itself, but the time that the district may take to administer the program itself, is eligible for Medicaid admin claiming, which is 50% a Fed. So right now, Alaska is not claiming for that at all. And that would be another opportunity for improving claiming for the state. So Joe, I'll leave it with you moving forward here.
Great, thanks, Rich. So some of this will be duplicative, I think, and maybe reinforcing a lot of stuff that Lena had in her presentation earlier. But you know, since our report initially came out, and this has been kind of a big for folks working in the school-based Medicaid space, May 18th, 2023 was a very significant day that it was CMS put out their new program guidance for school-based Medicaid programs, the first time since 2003 that they've put out any new guidance related to this program. It was mandated as part of the Bipartisan Safer Communities Act that was passed in June of 2022. Obviously, a focus of that act was to increase access to mental health services, but also to physical health services as well. And by providing more options for states and more flexibilities for states in administering their school-based Medicaid programs. So states under the guidance, states that have existing programs have 3 years to make the appropriate changes to their programs to come into compliance with the guidance. You know, that date is tentatively set for July or June 1st, 2026. So states are going to be pretty active over the next 2 years, working to come into compliance with it. And I think the degree to which states are going to have to come into compliance really kind of depends heavily on what their program looks like today. States that are currently running cost-based reimbursement methodologies that require the use of a random moment time study are going to be more impacted. They're going to have to do a lot more lift to come into compliance than, say, a state that is not pursuing a cost-based methodology that's just being fee-for-service, that's just billing fee-for-service traditionally. That there's not as many moving parts that CMS isn't really requiring states to move to cost-based. They're providing opportunities and flexibilities across the board to states when it comes to operating their program. Some of the flexibilities, the big ones to highlight, we've hit it already, is the expansion to cover services for students under a 504 plan, the free care expansion. So again, CMS is not just opening this up, they are actively encouraging states to look at expanding their coverage beyond the traditional IEP, IFSP, or 504 plans, really kind of emphasizing access to behavioral health services and to nursing services within schools. That's not to say that all of your other services, your speech, OT, PT type services aren't eligible as part of the free care. They 100% are, and we've seen states that have moved to expand access to the full range of school-based covered services. But really, you know, the emphasis again is really being placed on the behavioral health side, the mental health side. Reimbursement rates is another place where CMS has indicated some flexibilities for states that are in a cost-based methodology. They're allowing those states to establish rates in excess of community rates as an acknowledgement of some of the higher costs that are incurred within a school setting. So traditionally, CMS has restricted rates in the school-based setting to only be to basically be capped at whatever those same services would be paid for in a community setting. CMS is now acknowledging a willingness to pay it above and beyond those community rates for schools provided for services provided in a school. The other part, and we've talked, and it's been mentioned a couple of times as well, is an acknowledgement on the provider qualifications, that there are some providers, and CMS has historically said no to providers like school psychologists, school social workers, because they're strictly delivering services in schools. But now CMS is indicating a willingness to consider them eligible to provide Medicaid reimbursable services. However, that comes with the big caveat is it's not just a open gate of, hey, all of these providers that historically we've said couldn't bill for Medicaid services can now bill. They are still expecting that those providers would meet the comparable state standards and state licensure requirements for those services. So it's not just like I said, an open door. It is that school psychologist could be eligible. However, they have to meet comparability requirements for licensing purposes with community-based psychologists. Peter, anything to add on the federal landscape of things?
One of the things around administrative claiming, there was a requirement that a time study had to be done. There is still a requirement, but to aid participation by smaller states, they have lessened the requirements in terms of the sampling statistical requirements that need to be met. And what that means is it's going to lower the administrative burden on smaller states. To do that, before you had to sample, several thousand moments. When you have a smaller state with not that big of a population, that puts a pretty big burden on the school districts and their staff to have to do those moments. It's not too bad. I mean, they take about 5 to 10 minutes a piece to do it, which is not a ton of time, but I know my wife works in school, has a huge caseload of kids, and it's one thing if it's one moment. It's another thing if you're a smaller state, you may have 5, 6, 7 of them across a time period. But some of that flexibility means much more administratively feasible. We're able to cut that time down by a third, which really then opens it up for some other states that hadn't been participating in that before, just because of the burden on people, on the staff in the district. So this would be a huge option for the districts in Alaska.
So I think that was it in terms of the slides we had to present. And I just reiterate some of what Rich said, some of what some others have said. I think, going back 3 years now, when we first looked at this as an opportunity, I think there's definitely a pathway forward for the state as it relates to increasing reimbursement, just for the existing population, the existing services you have, that there is a pathway to accessing increased federal dollars. And the thought is that it's an increase in federal dollars without having to make an investment of new state dollars, that it is leveraging costs and expenses that are already being incurred at the district level to support accessing those federal funds. That when you combine that with the ability to expand and cover additional services, cover additional students, that has the increased opportunity from a financial perspective, and increased benefit obviously from the overall ability to meet the needs of students, where they're generally spending most of their time in that school setting. And so I think right now the landscape at the federal level has never been better for states engaging with CMS on ways to increase access, to increase reimbursement for the school-based services through the Medicaid program. So with that, I will stop talking and see if there's any questions. I didn't see any in the chat, but not sure if there's any. Yeah, and Peter, so there's a question about how Alaska could decrease administrative burden for smaller districts.
Yeah, so
You could just restate that.
yeah, so one of the things that has to be done in a cost settlement calculation, which is a time study to determine how people how they spend their time. CMS has lowered the sampling thresholds that need to be met. So what that means is we'd have to sample a lot less moments across the state to get the results that we need to calculate those cost-based reimbursement factors. And so instead of somebody having to do potentially 6, 7, 8, 9 moments in a quarter through a time study, the new guidance significantly reduces that by a third. Now, the guidance talks about some additional ways to potentially adjust what you're doing in terms of billing and services. That does not in any way, shape, or fashion get rid of the documentation requirements that districts have of documenting those services. Those are embedded in education law and regulation. CMS also still expects those services to be documented by staff, but there's just some options around the time study that make it a little bit more administratively less burdensome for districts. Moving to what Rich talked about of a CPE versus an IGT means a district wouldn't have to upfront provide that state share back to the state only to get that later. So it's a decreased step on the business office and the school districts in terms of that perspective as well. So the sampling is typically done statewide for the time studies that are used to calculate some of the reimbursements. And so obviously, if you only have to sample a third of those moments, it just makes it a lot easier for those out there that are participating in the program. I hope that answers, Maureen, your question.
We have a question in the chat from Melissa. Can you guys see that?
Yep, we can. I'll just read it. And can you expand on the current state match requirements to LEAs in Alaska who participate in SBS Medicaid under the current program? So, Rich, I think you can speak to it from the report you wrote, but our understanding there, Melissa, is right now there's an expectation that districts are responsible for transferring funds through a mechanism called an intergovernmental transfer, an IGT. And so, right, Medicaid is that state share, state federal partnership. The state has to, and I use the term state in air quotes, has to put up a portion of the funding for any Medicaid services before the federal government will kick in their portion of it. So under the current program, the state is asking the districts to transfer dollars over to the state through an IGT process. The state then leverages that money that the districts have transferred to them to access the federal matching dollars, and then the state would pay the district back for the total cost of that reimbursement. So let's say you provide a speech therapy service and it's a $20 per unit reimbursement rate. And I'm blanking on the Alaska matching percentage off the top of my head right now, but let's just say it was 50-50, which I know you guys are higher than that. But if it was a 50-50 match split, you would transfer $10 to the state. The state would take that $10, put it up for federal matching dollars. They would then be holding $20 and they would pay the $20 back to you for that delivery of the service. So
yeah, sorry,
Rich, anything to add on that?
No, what I was saying was not the federal matching rate. There's a percent in the state plan that is a percent of the fee that would be paid. There's like a fee schedule that's referenced, RBRVS, and basically saying we'll pay 85% of RVS as the fee, but I didn't mean the federal match on that.
Yeah.
No, that was well described.
Any other questions? Okay, well, Rich, Peter, and Joe, thank you so much for just being here, for being willing to share, for doing all of that work in the midst of COVID and beyond. We appreciate the perspective and the recommendations. We're gonna conclude. We do have, don't log off yet. We have some announcements, kind of some thoughts on next steps, and a survey link that we're going to share. But I just want to thank everyone for just being here again and for just engaging. You know, Eric commented just about the diversity of this group, and I think that just speaks to the importance of this issue. You know, Alaska is facing challenges and for our kids, right? Related to mental health, related to school funding. Expanding school-based Medicaid doesn't solve either one of those challenges, but what we've heard today, I think, demonstrates that this is a strategy that might be part of working towards a larger solution related to some of those really big complex issues that the state's grappling with. So ACT just really looks forward to partnering with each of you on next steps to support this effort, and just hearing back from you on kind of how you might want to move forward, what other information you need as we really look into this issue. So before we conclude, I'll turn it over to Teresa for just some final announcements and housekeeping. Oh, Teresa, you're muted.
Thanks, Jen. I apologize for that. But yeah, I just wanted to say thanks again for everyone's participation today. If you could please take a moment to complete our post-convening survey, it would help support future planning, connection, and other advocacy efforts on this issue. Jen's going to put it in the chat. It'll also be shared in a follow-up email that you'll receive from me or Jen soon. But I also wanted to take a chance to announce that there will be continued opportunities to learn about school-based Medicaid through a webinar series being sponsored by the Anchorage School District. The series is going to be called Exploring School-Based Medicaid in Alaska, Learning from National Examples. The first two webinars are going to focus on Michigan's system and are scheduled for December 14th, starting at 9 a.m. And then January 18th, also starting at 9. Jen is going to put the registration link in there. And I know I'm going to be tuning in. So thank you, Anchorage School District. Again, thank you so much for coming, everyone, and for your commitment to Alaska's children and families. Have a wonderful afternoon.